a nice summary of, and more to come, of a variety of different types of big data. And I'm going to take a slightly different slant because I'm coming from a field in rehabilitation where we really don't have data to work with in many cases. So big data doesn't exist in the same form that it exists in other arenas. We lack a lot of standardization of outcomes, and I'm going to run through kind of some examples. I'm also going to set the stage for what Andy Kittleson's going to talk about this afternoon in his forum, which is focused on dissemination implementation. So I'm going to try not to steal his thunder and focus more on the data management pieces, how we got where we are, and he's going to talk more about some of the next steps and the elements related to the implementation piece that still surround the central project or the central population that we're working with, which I'll describe in just a minute. So I'm going to talk, I'm going to cover kind of some elements of the challenges associated with not routinely collecting outcomes, practice patterns that are extremely variable in rehabilitation. Patient satisfaction is typically the main goal, which makes it difficult to collect some data, and I'll explain that in a little bit more detail. And the fact that physical functioning often doesn't correlate with the patient-reported measures of satisfaction. So really, at the end of the day, the approach that we've taken is we have to generate our big data from the beginning prospectively. We have to set the stage for developing the data sets that we're going to use down the road. So when I first started talking to people about how we could use big data and implement some of the things that we wanted to implement, it became painfully obvious that when I was asked questions about what exists in the databases, that there really just wasn't anything there that I could draw upon other than age and sex and maybe some demographic types of variables. But there really wasn't, we don't have standardized, everyone gets a blood pressure assessment, everyone has a height and a weight. There's really a ton of variability. The population that I'm going to be describing, just to give you a context for the importance of this work in the near future, is focused on total knee arthroplasty. And so I think everyone in this room is probably well aware of the aging population of baby boomers that is going to continue to increase in age, obviously, and increase in terms of the need for services. And one of those services is knee arthroplasty. Right now, it's ranked third in the United States for inpatient procedures and first for the age group of 65 to 74. And this just kind of demonstrates the exponential growth that we expect. So we see about 700,000 knee replacements done each year in the United States. And by the year 2030, which is coming up fairly quickly, we anticipate we're going to see 3.48 million knee replacements. So that's a pretty substantial increase, and we need to figure out how to improve treatment paradigms using the data that are available. So, or prospectively developing data sets, as I'm going to describe. So really, the challenge in the field of rehabilitation is everyone wants to kind of tweak and modify, and hopefully this certainly applies to other areas of study that some of you are engaged in, but people want to kind of individualize the approach that they're taking in rehabilitation. People want to have their own say as to how they interpret the guidelines, how they deliver a treatment, because the idea being that you really want to as an individual therapist, shine above the rest by individualizing your approaches. But the reality is that there's data to suggest that we need to get everyone on the same page and do the same type of treatment, and that in itself is going to improve the data that we can use on the back end. And so there was a great example through Intermountain Health, which is over in Utah, where they looked at the large variations in treatment processes, and this was across and within expert therapists, and they decided that they were going to do something as simple as implement a very standardized protocol. So in looking at this protocol and working in this area, the protocol came from some of the work at the University of Delaware, some of the concepts that we use here. Solid protocol, certainly not what I would consider to be the absolute best protocol available, but very solid protocol. And I'll come back to why that's important. And they built it into their workflow. They made it automatic. They instituted processes where therapists could not deviate from the expectations of the protocol that they had developed. They did have some mechanisms to vary things on patient need, but they were still guided by milestones, and I'll show you that in just a second here. And the variances in the patient outcomes were put into a lean learning loop. So the therapist got some feedback as they were going to improve their processes. So they were able to get information. Andy will talk about this a little bit more, I think, in terms of how do we give information back to the therapist to create a real living database that's useful to them? Because if we want them to collect data, we have to make it useful to them in order to sustain the operation. And so the intervention that they chose had some milestones here where they really had some guidelines for pain and strengthening, range of motion. So they had some very, very specific things that the therapists were asked to do. And again, I can tell you that I liked their protocol. I'm not sure that it is the absolute perfect protocol, but it was very solid. And even with this protocol, they were able to show that the average number of visits by standardizing treatment decreased from 2012, before they implemented this, to 2015, from 10 visits to 8.3 visits. And then they had a failure rate, which they defined with a self-report measure in terms of a 10% change or deficit, or that also decreased. So their failure rate was not nearly as great as it was before they implemented the standardization. So that's been a really big focus, is trying to get these data sets, to get therapists to collect these data sets in more standardized manners. And I'm going to just touch briefly on why we're doing what we're doing in terms of an emphasis on functional performance data, which are really the hardest data to collect. So it's a lot easier to give patients a questionnaire and have them in a survey and a tool and have large data generated. It's a lot harder to collect data where you actually have to measure something. You have to have someone perform an assessment, and you have to standardize that across the evaluators. So knee replacement surgery, for anyone who's not aware, the primary reason why people get a knee replacement is because of pain. And what we see, though, is that despite the success of the surgery, we have long-term deficits in strength and function compared to healthy adults. And so this is illustrated in really poor functional performance, which is why that's the focus of a lot of our outcomes collection. So when we look at healthy individuals over here on the left, this is a stair climbing test. And so healthy individuals are able to go up and down a flight of stairs in less than 10 seconds, whereas individuals anticipating a knee replacement surgery take closer to 23 seconds. A month after surgery, that almost doubles compared to their pre-op value. And then 3 and 6 months and even out to a year, they're not a whole lot better than they were before surgery. And they're certainly still different from the healthy individuals. And the 6-minute walk data that we collect, so patients have to walk for 6 minutes continuously, or not continuously, but you have to see how far they can walk in 6 minutes. And you see the same pattern. People who are healthy have really good 6-minute walk data in terms of distance, and patients before surgery have a deficit, further deteriorates after surgery, bounces back to preoperative levels, but never to the levels of healthy individuals, even after a year, 6 months. We also have data at a year to support that. So here's the important piece in terms of some of this is what's the most important data to collect. And when we look at outcome measures related to patient report of how they're doing, this is a scale that looks at activities of daily living and has a number of other subscales. But if you focus on the blue here, the activities of daily living, and the red, which is pain, you see that the activities of daily living score, the patient's self-report of what they're doing in terms of daily activities, parallels their reduction in pain. So a month after surgery, they have a substantial reduction in pain right here, or an improvement in pain, and they also have a corresponding improvement in their activities of daily living, their function, their self-report of what they're doing. But when we test these same patients in our laboratory setting, and we ask them to do the same tasks that they did with their that were assessed in the questionnaire, functional activities, we see a completely different story. So we see that, again, this is the blue that was present on the previous screen with the activities of daily living self-report assessment. And when we ask them to do things like stair climbing, 6-minute walk, timed up and go, which are roughly the same types of things that are queried in the self-report assessment, we see an inverse trajectory of what they're saying they can do compared to what they're actually capable of doing. And so this drives a lot of the emphasis that we have on, we have to figure out ways that therapists can measure physical function and not just ask a self-report question. And so I've talked a little bit about how the pain influences that and drives that. And so we typically, so the one data point that is available on a large-scale database in this population is knee range of motion. And we can collect that on almost any patient at any time point in almost any medical record, because that's like the hallmark of what defines success and failure. But, and then more recently, we have monitoring of self-report outcomes. So there's a mandate by Medicare that is coming into place that we collect, that the physicians collect more self-report data and as standard of care. But again, I'll tell you that despite the fact that there's an emphasis on flexibility and self-report, the driver for actual outcomes, the driver for how patients do after surgery is strength. And so the functional measures that we're collecting are really probably more indicative of prognosis and long-term performance in these patients. This is the COOS Junior. So this is the new survey tool that's being used. And April 1st, this kind of has been pushed out as part of a new bundled care initiative in joint arthroplasty. And so physicians are being encouraged, right now encouraged is probably the right word, mandated will probably be coming down the road soon, to ask these questions, which again are very similar to the questions that I've showed you with the Activities of Daily Living score. This is just a shorter version of the previous scale. And so we have spent a lot of time with a group of clinics as well as physicians on this campus and other growing into other physician groups, where we're trying to teach individuals, to do these timed up and go tests and walking speed assessments, as well as the 30-second chair rise test. And obviously, the importance of choosing the right outcomes is going to define, what we're going to use, what we can use down the road. So we have, and how it's going to inform our decisions as far as clinical practice. So we have some outcomes that have a low floor effect and kind of but basically are easier for patients to perform. And we have some that really evaluate higher levels of function, like the 30-second chair rise. And what's interesting, and then also quadriceps strength, which is an important predictor of function, and certainly a muscle that's severely impaired with this particular surgery. What's interesting is that these tests look really straightforward. I mean, the timed up and go test, you get up out of a chair, you walk 3 meters, turn around, sit back down. But there are a lot of deviations in the simplest measures in terms of the implementation, the performance of those. And so it really has taken a lot of time to make sure that the quality of the data that we're collecting is going to be usable down the road. And I'll conclude, because again, Andy's going to build upon this with, this is just a sample of one of the data collection forms we use. There have been a lot of issues other than the consistency of data collection, but there have also been issues of EMRs changing over. And so how do you take, you're halfway through your data collection in terms of amassing this large data set, and a company gets, or our therapy clinics got bought out by another larger company, which in the long run has a lot of benefits because we can apply what we're doing on a larger scale, but in the short run requires us to figure out this data linkage and trying to, and also, or not even data linkage, but what data can we use that's common across these databases, the before and after, that we're still going to have a usable data set. So certainly problems that I think will be brought up by other speakers as well, and Andy will highlight further in his presentation this afternoon. So I will end there and take any clarification questions, I guess is what clarifying questions, or just go to the panel.